I was wondering if you're still taking questions. One for Dr. Cannon, very cool talk. I wanted to know if taking mexillatine, which is a sodium channel blocker, while taking bumetanide, if that would prevent bumetanide from having the positive effects seen in HKPP. So
HK, she's referring to hyperkalemic periodic paralysis?
HKPP, that's all we got.
Okay. So, bumetanide in our mouse model was not beneficial in hyperkalemic periodic paralysis, at least our one mouse model, so it was only hypo. But she does raise an interesting question about mexillatine, which you've heard about in the management of myotonia. It's a drug that primarily blocks and inhibits sodium channel action. And so you might think if you have hyperkalemic periodic paralysis due to inappropriately open sodium channels, which is the primary problem, that these sodium channel blockers would be beneficial, but they're not. And that's still a big mystery in the field. So again, mexillatine, of value, as Dr. Trivedi's study showed, in lots of forms of non-dystrophic myotonia, chloride or sodium channel based, but there is not a role for bumetanide in hyper-KPP.
Okay, thank you. I'm sorry, did you address the mexillatine thing? Or?
Well, right now there would be no reason to take both because there's no role for mexillatine in hypo.
Gotcha, understood. Okay, fine. Very good. I'm like double tasking. Okay, so the next question, I would deeply appreciate, ask the following question. After many years suspected, others from Kathleen in Ireland, many years of hypo with genetic testing in Germany negative. I now have a verified diagnosis of hypo in the past 2 years based on clinical symptoms, result of a CMAP done in the hospital on 2 occasions in attacks. My attacks are resolved with oral potassium reliably. I'm on a high daily dose of oral potassium. My big difficulty is that the doctor and neurologist in my country do not accept that I can have hypo-PP because my blood tests are always in the normal range in paralysis attacks. So 4.2, 4.4. Can you help me explain this to my doctors? So, but didn't she just say she had low potassium? Oh, potassium helps her, but she has normal. So she has normal potassium in attacks. CMAP is positive. How do you explain that? Is that a valid diagnosis? Jack?
Okay, that's a tough one too. So the good thing going in her favor of diagnosis, going in favor of her diagnosis is that she has an abnormal CMAP, an abnormal prolonged exercise test, I take it. And we know there's difficulty in obtaining a low potassium, or actually high potassium is very much harder to find than a low potassium. But if she has an abnormal CMAP, a prolonged exercise test, and she has episodes that respond to potassium, then perhaps that may be the diagnosis. And how does she convince a neurologist? I think for physicians, it's important to find something objective. Even when there's lack of objective evidence, we still feel that, okay, the diagnosis may be real, but when there's some objective abnormality, then I think that is most convincing. So we know that abnormal CMAP indicates periodic paralysis, be it primary or secondary. She may talk to some neuromuscular specialist who understands this test and can get further testing to make sure there is no kidney or adrenal gland problem or thyroid problem, and if none exist, then a neuromuscular specialist who sees the CMAP test and sees it's clearly reduced for a long time, not just for a few minutes, then that should be helpful in nailing the diagnosis and helping her with further treatment.
Yeah, I mean, obviously the situation she's presenting is, again, one we're encountering all the time, and how do you make a doctor acknowledge a diagnosis that even you have an objective test, it's not even, anything that's subject to negotiation or whatever, interpretation. That's very difficult.
I think the caveat here is to make sure that the prolonged exercise test was done properly. I think that is the most important thing. Because if patients might be very concerned with the CMAPs, but I think if a neuromuscular specialist sees the pattern, make sure it's done properly, then that should be more convincing.
Okay, our webinar had crashed the other day, and so we lost a bunch of questions. What I'm going to ask the people in the webinar to do is please submit any question that we don't get to today I'll try to get to whatever we have here, but if not, please submit them to PPA Ask the Experts, and I'll email to the appropriate doctors that have been here today, and we'll get answers to you. So, just give me a second here. Please show us the stretching. Can you make it where we can see her, please? Yeah, it's a tough one. Sorry about that. Well, yeah. Maybe you can make a video or something. I don't know. Okay, yeah. So I don't see too many questions here. But did you have a comment?
Okay, hi guys. I made you the group picture, and I want to say to you that if you'd like to have like a portrait or something with one of the people over here, just ask me, because I'm here and I brought my camera. So I just wanted you to know.
Yeah. How are we gonna access that group picture? Is that something that like?
I'm gonna email it or put it on. I'm gonna email it to like Linda or to someone who is in charge of contact with everyone, or we can put it on the internet. So we'll figure it out, and I'll let you guys know.
Yeah, we'll find a way to put it out on Dropbox or just email it to everyone at the conference. Vicky wanted to have one comment, and the blood drawing, there was a couple of people that needed blood draws. I'm going to remain here to do that. Rosen asked us to leave here by 1, but between now and 1, we can hang out a little bit, I think. And does anyone else have questions in general? Just want to get a kind of idea. So two folks here. So we'll do.
There was a question that was asked of me privately that I realized would be important to explain to the group. If you have the lidocaine not working, what should you do? And our original paper about this was written with a dentist at Harvard Medical School, so we have something that you can give to your dentist, and the answer is you can use another drug called articaine, which is similar to lidocaine, but it works. And there are, at least in Boston, we have ads on the radio saying, do you have dental anxiety and you don't want to go to your dentist? My guess is a lot of what's going on in those situations is those are people who lidocaine doesn't work and they're in agony at the dentist, and you don't have to suffer like that. You don't go to these guys who'll put you under general anesthesia. You just tell your dentist in advance that to get some articaine, and that works, and it's fine. And for non-dental things, other drugs like bupivacaine and bupivacaine will work, and so it's just there's something about lidocaine that doesn't work well, but some of the other drugs in the same category do work well. So there are things you can do, and you don't have to suffer in this way.
Questions or?
How bad is the brain fog going to get before you think you probably need to do something about it?
Thank you. Sorry, Dr. Siegel. How bad does the brain fog have to get before you think you need to do something about it? I would just comment on that. Insofar as, if a hypo got brain fog, I kind of put that into an attack. And, then I would take measures to do whatever gets you out of an attack. And that many times should help. But I'll let you comment.
That's basically what I would have said. It's obviously if you're in the group that's taking one of these carbonic anhydrase inhibitors, suspect the drug, but otherwise treat it as part of an attack and do as Jake described.
What about memory? Is it deleting old memory? I don't think so. It shouldn't. I mean, if it does, that's a different phenomenon. Oh, there was a question. There was a couple of questions. Okay, go ahead.
I had a question in regard to the lidocaine. Should we be avoiding the lidocaine with epinephrine in it? Is it my understanding that we should be asking for epi-free?
Lidocaine with epinephrine is a trigger for hypokalemic periodic paralysis. And
let me explain that there's two issues here, and this is a good opportunity to clarify both of these. So So one is that with some forms of periodic paralysis, there is a problem with general anesthesia that you get malignant hyperthermia. This is different from that. And then in the lidocaine issue, yes, the epinephrine is important because the issue that we're describing is the lidocaine doesn't work well. But as you point out, and as Dr. Levitt pointed out, there's a second issue that lidocaine is often given with epinephrine, and the epinephrine can trigger paralysis episodes. So it's very complicated that there's two different issues with anesthesia. One is local anesthesia, like in the dentist or a little injection. The other is general anesthesia, and it's important for you to explain to your dentist or doctor who's giving you an injection of a local anesthesia that adding epinephrine is a problem, and they can get lidocaine without epinephrine. Some of the issue with some of the articaine preparations, I think, do have epinephrine, so that may be a problem for some people. I don't know about dental use of other drugs like bupivacaine. I've heard that people have used those, but it's a complicated issue in that there are other drugs, but some of them come with lidocaine, and lidocaine can be a problem.
There was a question, is there a treatment for the myopathic type of hypo-PP, meaning the permanent muscle weakness?
So to date, there's no approved or widely accepted treatment. Again, there was concern by many physicians that it would be irreversible because of the appearance of the muscle in biopsy. The one caveat is that when Professor Langenhorn began doing sodium imaging studies and tried carbonic anhydrase inhibitors with some individuals with so-called permanent weakness, which is how he likes to term it now, they've regained some level of function. So I would stay open-minded. I think the only report that I'm aware of where we've heard some change in level of functioning was upon starting carbonic anhydrase. But there's no evidence that that can prevent or cure, but symptomatically they had higher level of functioning.
Yeah, I guess I would add that if you've never been if a patient has never been treated, what is permanent muscle weakness and what is a kind of long attack. So you want to sort out what is reversible and what isn't, and you can, with the carbonic anhydrase inhibitor or appropriate potassium therapy, gather at least whatever's functional, make that functional, so you cut down on what's permanent. Question.
How do I find a neurologist that has treated other people with periodic paralysis in my state, near my state?
That's a good question. The PPA has developed this thing, periodic paralysis, find a doctor. And the concept was that all of us, if every single one of us, 2,500 members, each input the doctors that they use they've been successful with, the idea would be like this kind of crowdsourcing of identifying, it doesn't matter, primary care, neurologist, endocrinologist, whoever that works well, and then we could all use that information. It's difficult for me to say, is this a good doctor, is this a bad doctor, what's good for one person, maybe a drug for another person, etc. But at least we'll have somewhere to go. The other thing is the Muscular Dystrophy Association has centers of excellence, and major university medical centers tend to see, things that the general docs can't deal with. So as a general rule, that's what, for any condition in any specialty, that's what people might suggest. Do you have anything different to add?
I think it's a great answer.
Yeah.
Okay. Next question.
Question on that find a doctor though. How are you guys keeping up to date?
Yeah, I see what you're saying.
Retire or
No, we're not keeping it up to date. Unfortunately, it's one of those things that there's no time. I mean, if someone wants to, volunteer and we can figure out a system without bothering the doctors by constantly barraging their office, but that would be great. We should keep it up to date. But I guess it's a trial and error kind of thing locally. Questions from the back?
I have a question going back to
medicine and the effects of medicine. I have a bad reaction to all drugs that affect long QT, even though I don't have long QT. I haven't been shown to. I'm hypo in the normal range, and I'm just wondering is, even though they tell me that I don't have long QT, things like albuterol, Cipro, some allergy medicines will drop my potassium, and so now I put that as like I'm not to take any of those. Do those medicines affect all patients that are hypo, or am I predisposed to long QT, or what should we be looking out for?
So I guess, do you guys have a mic? I'm going to let Steve or Jaya take that one.
So the question, correct if I'm mistaken, is about, do you have a tendency or does everybody with hypo-PP have a tendency to react adversely to certain medications and that causes prolonged QT? Meaning, is there a tendency for hypo-PP patients to have prolonged QT? I think that's the question.
No, yeah, so I end up, so if I've taken albuterol, I don't get long QT, but I've ended up in the hospital because my potassium drops so low, and I start, essentially it sends me into an attack. And I've talked to a few other members here that had the same thing. They reacted badly to these medicines that affect long QT, and it dropped their potassium. So is that just something that's common with everybody, or is it just with, hypo patients?
It's interesting. Albuterol is a beta agonist, and that medicine does have effect on the sodium-potassium pump, and that is why those inhalers are used in the abortive or the acute treatments of hyperkalemic periodic paralysis. So what they do is they drop the potassium at that time. So yes, theoretically, and what we have found is those kinds of medicines can drop the potassium. So in hypo-PP patients, that could be a problem. But do I know about other medications, the Cipro or the Levaquin that you mentioned and the others? I'm sorry to drag a blank out there. Having said that, there are some medicines that can affect the kidneys, like the furosemide or other medications that lower potassium level. So certain medicines we know can lower potassium, and albuterol we do know can do that. But of all the antibiotics, I'm trying to think.
Well, I think that as I interpret the question, there's three things. One, are there some medicines that across the board make hypo people, are triggers for hypos? And insulin drives potassium to cells, albuterol drives potassium to cells, potassium-wasting diuretics, you lose potassium, those things would be common triggers. There are drugs that worsen long QT syndrome. So if you have Anderson-Tawil syndrome, and one feature of that by definition is long QT, you have to avoid a whole barrage of drugs that make the QT interval prolonged and predispose you to torsade and ventricular fibrillation. Then the question is, are those long QT drugs things that may cause low potassium? And I would argue there's probably no relation to that, but in any individual, any drug we take, and it's new, you always have to wonder, what's it gonna do to me? And some people will have drugs that you wouldn't predict lower potassium, but there may be a trigger for you.
One other thing on this is people with these channelopathies tend to have cardiac effects. The heart is obviously run by channels, and we know with the ADHD channelopathy people that there have been lots of instances of rapid heart rate that they have under various circumstances, some of which are drugs. One of the people whose adverse drug report got Seldane removed from the market was one of the channelopathy ADHD patients, and she had very rapid heart rate after this drug. And so there are all sorts of things that go on, but this group is definitely more susceptible to cardiac effects of other drugs.
For my daughter, she's in corticosteroids, affect her, prednisolone, albuterol. I've asked our pharmacist to put an alert for her for prescribed medications that might cause potassium to drop. But what about over-the-counter medications that we take on, people don't consider? I mean, she's developing this, so things that she used to be able to tolerate, like albuterol, she no longer does. So it catches me off guard. And the last time she went to the ER was because I gave her a decongestant, which is an over-the-counter you don't think about. And then I'm going, well, what about cough medicine? What about expectorant? And those are the things you got used to grabbing at night when your kid wakes up sick in the middle of the night. So is there any comprehensive list of medications that cause potassium to drop?
Jake, do you have the answer?
Well, I mean, comprehensively, I mean, epinephrine, the ones I said, the insulin, epinephrine, there are some that may accelerate your heart rate, and insofar as you have an accelerated heart rate or any sense of anxiety, phenylephrine, I would say, would be one of those things. It probably would cause, in some instances, your own body to make epinephrine, and that would drive you to attack, just like people get scared or something. And things that, I guess that would be mainly it.
Yeah, I feel like I'm endangering her by creating her more basic common cold.
Yeah. The other thing is, the triggers are funny, right? We talk about, rest after exercise. There have been instances where I was shivering, not because I'm so cold, and cold for me isn't the trigger, but the shivering is a muscle activity, and that can get you paralyzed. So there's all these little subtle things and there's a little intermix between medications and your body's reaction of why that happens, versus just a straight-up pharmacologic dive of potassium.
I just have a quick question that came up. As a caregiver, is there, in the middle of an episode, too much potassium to give?
That is a concern, giving too much potassium. Because if you don't know what the potassium state is, if the patient's kidneys are not healthy, then theoretically giving so much potassium, it can affect the heart rhythm. The other thing is, in patients with periodic paralysis, when you give potassium during an attack, remember at that time it's doing something, but afterwards there will be a shift. And that shift, where suddenly you have too much potassium in the blood later, can also be dangerous. So you have to be very careful. You start low and gradually build up. And like everybody's talked about, everybody's different. What works for somebody may not work for the other.
What I would say is that, it depends on the severity of the attack. If you're in a very dense attack and you haven't had potassium, you have a pretty decent window about how much potassium you can give. As things get a little better, you can go a little more slowly. But if you're in a bad way and you need to get it over quickly, you have to give a reasonably high dose. Different people say different things in terms of, I've met people at conferences who say they take 200 a day. That's a lot of potassium a day. Usually what happens is, provided you're taking it over some 2, 3, 4 hour period and you take 200 and you're not used to taking it, you'll get diarrhea and the potassium will go out that way before getting toxically hyperkalemic on oral stuff. But there is a dose at some point, I don't know what that dose is, but we throw 200 out there because it seems kind of reasonable that you can really get into trouble if you take even that much oral.
Your body can become used to a certain level. So you might need more the next time?
Yeah, and guys, please correct me if I'm wrong. But if someone takes 60 or 100 potassium every day, the kidney upregulates its protein channels to maintain homeostasis. So what's normal for a regular person, like if you take 100 a day all the time, a little bit extra potassium is not going to affect you that much. But if a normal person took 100, it would make a big effect. So you can kind of get, I think, a little accustomed to that. Does that make sense?
Right, it makes sense. It's a very good answer there. But the other thing I want to say is, we check kidney function tests, something called B1 and creatinine. And at some point, if that has not been monitored, and for some other medical reason, say perhaps diabetes, complication, the creatinine starts going up, then you have to be very careful with the potassium you take, because then that's getting to be dangerous for the heart. As long as you have healthy creatinine function, you should be able to pee out the potassium. But at some point, if you don't get it checked and it's going up, then taking the same dose of potassium could get toxic. So just start low and gradually.
And the other thing is, if you see that you've taken 120 and you've never really taken that much before, at some point you have to go to the hospital and know where you're at, check the potassium, and then kind of go from there and adjust as you need it.
Let me just add one more comment to that. Everyone should know that giving a lot of potassium quickly intravenously can easily be lethal. All doctors will know this, but it's just worth you knowing it also. And since Dr. Liebenhorn isn't here, I've many times heard him make the point that, yes, you have to be careful when you're taking very high levels of potassium, that the body does get used to getting rid of that quickly. And so that's one of the reasons he likes to give some potassium and some other drugs as well, but not depend exclusively on potassium.
I just wanted to say, I had a study done with my doctor. She doesn't really know about this rare disease, but she's been trying to really help me. And every time I have anesthesia, I've had 12 surgeries, so I've had a lot of anesthesia, and I've almost died after every single one. And they couldn't figure it out until I got diagnosed with this. So we did a study last year because every time, even if I just had the smallest anesthesia where they said it wouldn't do anything, like a 10-minute procedure, they said I would be fine, and they would tell me that every time, and then I would go home the next day and I would almost die. And so this time I had a colonoscopy and endoscopic. They fought with me and they said, you will be fine, you will be fine. Finally, God's will set in, I'm shaking, sorry. God's will set in a different anesthesiologist because something happened to the other one and they had to be with a different person or something. And they sent in a woman. And the woman came in and she's like, she looked at my records and she said, this is ridiculous. You are not going home after you have this colonoscopy and endoscopic. You're staying here. You have a record of collapsing and your potassium dropping down in the tubes, and you're not going home. She's like, you're under my care. And I'm like, thank you, God. So what they did was they got me pumped up to a 4.4, okay? Within 10 minutes, they did the colonoscopy and endoscopic. I was a 4.4 they had me pumped up to. Immediately, as soon as they did my blood work, within 10 minutes, my potassium dropped to a 3.2. So that right there proved that anesthesia, as soon as I take it, it just starts dropping my potassium. And I do the shake thing where after I have the surgery or just anesthesia or anything, where I get really, really cold and I start shaking. And every time they send me home, I get this severe headache. And yesterday, I kind of missed it where they were talking about the paramyotonia. I kind of missed it. I caught it at the end, but I was curious because my doctors kept telling me, well, I'm not sure it's just hypokalemic, my neurologist, because why do you, when I go into the attack after the anesthesia, my eyes close and I can't open my eyes and I go crippled up like a lobster. And he said, that's not normal for hypokalemic periodic paralysis. I went all the way to Rochester, New York for the doctors up there, Dr. Twall and everything. And he's like, you're not normal, you can't have hypokalemic periodic paralysis because your eyes close and you don't really know what's going on and your hands turn into lobster. But this happens to me every single time I have anesthesia. But I have also been diagnosed with another rare thing this year. And a lot of the questions from her and her, I was also diagnosed with mast cell disease. It's mast cell activation disease. And everything drops my potassium. I just got stung by a bee and almost died. I'm not allergic to bees, but because of all the histamine, it's to do with histamine in your body. You can be allergic to nothing and have too much histamine in your body and it attacks you. And a lot of the people that I've talked to, like I get severe pain in my legs. I had to go on the albuterol and they had to put me on the steroids, even though I can't have it with my hypokalemic. It dropped my potassium drastically. I had to be on 8 potassium a day of 20 milligrams to survive this. But it took me 3 weeks to survive it. And the medicines do. Like if I use an Oragel in my mouth, the lidocaine that's in the Oragel drops my potassium. If I have my eyes dilated, that drops my potassium. Just about anything I take drops my potassium. So I just want to let everybody know that.
So I think that two points that I would say that there are a lot of presentations that are not typical, and the idea that you can have paralysis, but then also some kind of stiffness, and that doesn't fall into a box, still doesn't, it means you have to pursue things. And I don't know, I lost my other point, but okay.
Hi. I've actually asked several of you here, and I've actually talked to a few of the doctors here, but about a couple months ago, I started having symptoms of Crohn's disease, and I haven't gotten an official diagnosis yet, but other people in my family have it. And I'm just curious, just as a general, like, asking everybody here, IBS and Crohn's both run in my family, and I've talked to a few of you and found out that a few of you have Crohn's, and I just kind of wanted to ask y'all like how y'all dealt with it, and just like when you have a flare-up of Crohn's, how you deal with the drop in your potassium, and how you deal with like what you can eat, and the correlation between what you can't eat with Crohn's and what you can't eat with periodic paralysis, and what might cause you an episode in one might cause you a flare-up in another, and just, I guess.
I don't know, Jai, you want to just, but that addresses the other point that I would say, that some of us have conditions that have conflicting things. If you have hypo and asthma, hypo and diabetes, hypo and Crohn's, you have a real problem, because the medicines that make you better for one make you worse for the other, and it's going to be a risk balance and a question of, if you can prophylax against the hypo and then take the medication for the other one, that's something that we can do. Now, we have to be out of here at we have to wrap up, so I guess 2 more questions. There's going to be Helen and Karen.
Thank you. This is, I guess, for Carly or whoever else may know. I have seen multiple physiotherapists throughout my life, and they've consistently documented that from appointment to appointment. At the beginning, I'll be able to do a number of certain exercises, or I will have full flexibility, and then as I do them, a few days later or a week later, each time it seems to be less and less. So if I could do 20 push-ups instead of being able to do 21 the next, not that I can do 20 push-ups, but if I can do 5 push-ups instead of the next time being able to do 6, I can do 4, and it goes down. And I'm just wondering, I guess, one, if that is found, if that's common with periodic paralysis, and 2, with that phenomenon of how a person would make a muscle stronger when it gets weaker like that. Thank you.
Great question. I think that goes to working with your physical therapist. We often look at numbers because we try to make sense of things. But I think that in this case, it would be better to look at functionally, quality of your movement, other factors. That also tells me maybe whatever you were doing was a little bit too much as far as intervention. So a lot of times if we're seeing a negative effect, which you would consider a negative effect, you're not able to do as much as previously, then it might not have been the right activity to do, or too much of it. So as being common in periodic paralysis, honestly, you guys would have to answer that question for me. It is common to see that in neuromuscular diseases when we've done too much exercise, and that it harms the body in that way.
Hi, my question is to anybody medical who knows the answer. Are there anesthesias to be avoided if you are a hypo?
I missed that question.
Are there anesthesias to be avoided if you're hypo?
Is this on now? The answer is yes. I'm not the expert to tell you about this, but some of the channels that cause this group of disorders are also known to cause something called malignant hypothermia. So that is definitely something that you need to tell people about this. And also, as people have pointed out, some of the local anesthetics come together with epinephrine, which can trigger attacks. So those are the 2 different things you need to know about. There are lists in terms of malignant hypothermia, of which I don't know, but those can be easily found.
Well, you have to talk with the anesthesiologist at the beginning, and they want to know exactly which ones they should avoid.
Well, there are such lists, and it's their job to know those.
Dr. Weber gave us a talk last conference or last conference, right? On anesthesia and periodic paralysis. The slides are on the internet, and if you email PPA Ask the Experts, I have like a kind of boxed, response that I have to that. And I am working with another fellow who was here last conference, and we're going to try to publish a paper soon on some guidance about anesthesia and periodic paralysis.
And for the long QT syndrome, if you Google QT drugs, you'll find an extensive list.
Okay, everyone. Well, I think that we have to call it. Just a couple of housekeeping things. If you want those zebras on the table, you negotiate amongst your table mates and take them home. There's a lot of extra bags in Purell. Please help yourself to that on the way out. And thank you for attending this conference. You all made 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 attending